All right, so good afternoon, everyone, and thank you for joining us. My name is Eliana Landa, and I'm the Physician Relations Specialist here at Rothman. Today's webinar is with Dr. Goltz, shoulder and elbow surgeon. His office locations are at Lake Nona and Innovation Tower, and his topic that he will be covering this afternoon is innovations in shoulder replacement. So just a few quick notes. At the bottom of your screen, you will see the Q&A icon where you can enter any questions that you have throughout the presentation. And Dr. Goltz will have the time to answer as many questions as he can. Also in the chat box, I'll share Rothman's phone number if you would like to make an appointment, as well as my information for any assistance that you may need. And this webinar is being recorded, and you will all be emailed the recording within a few days. So without further delay, I will pass this off to Dr. Goltz. Welcome, Dr. Goltz, and thank you for your time this afternoon.
Thanks, Eliana, and thank you to everyone for joining. It's really a privilege to be talking with all of you today, and I'm excited to share a little bit more about this topic, which is innovations in shoulder replacement. I'm a orthopedic surgeon here at Rothman Orthopaedics, specializing in shoulder and elbow joint preservation and complex reconstruction. So this is a topic that's near and dear to my heart, and lots of really exciting stuff to share with you. Shoulder replacement, I think, historically has been something that hasn't been quite as publicly accepted or recognized maybe as hip and knee replacement, but especially over the past 5 or 10 years, it's become something that we've learned a ton about and has really approached and even equaled the outcomes that we see in lower extremity replacements like hip and knee arthroplasty. So I'm excited to share with you some more about it. So just by way of a brief outline, I'll tell you a little bit about myself and what I do. We'll tell you a little bit about the shoulder. In order to understand these replacements, you have to know just a little bit of anatomy. It's nothing complicated or crazy, but that'll allow us to know what our options are for each patient. And then I'll talk a little bit about what the future looks like for shoulder replacements specifically. So I'm actually from rural Washington State originally, a small town called Walla Walla, Washington. The town's catchphrase is "the town's so nice that they named it twice." And back when I was growing up, it was a very small farming community. It is now actually a burgeoning wine region in Washington State. So there's 150 wineries within about a 15-minute drive of my parents' house. So it makes it a fun place to go visit now as well. But back when I was growing up, very different place. I went to college in New York City at Columbia University. I was in the engineering school there and actually lived in Brooklyn for 2 years following college, and then moved down to North Carolina, where I went to med school, business school, and did my residency training in orthopedic surgery at Duke University. There's actually some great Orlando Magic connections to Duke University. With the Magic are Wendell Carter Jr. and of course Paolo Banchero. So lots of tight Duke connections with the Orlando area right now. I'm actually coming down to Orlando from Philadelphia, which is where the Rothman Orthopaedics main campus is. It was known as the Rothman Orthopedic Institute before they changed the name, and you can see there that's the headquarters. That's down there in the bottom right. And just by way of introduction, for those of you who may not know as much about Rothman Orthopaedics, it was founded in 1970 by Dick Rothman. He was an orthopedic surgeon who was one of the instrumental surgeons in bringing total hip replacements to this country. And one of his big innovations in terms of practice management was a subspecialty focus. And so he believed that each surgeon should have deep subspecialty training in their area of expertise. And so every Rothman surgeon is fellowship trained in their area. And so as a patient, you can rest assured that if you're coming to see a surgeon about a specific issue, that they are fellowship trained and very highly capable of addressing your need. And Dick Rothman believed very strongly in serving the community and being part of the community, and giving patients and their outcomes our absolute priority. And so it's definitely really a privilege to be part of Rothman, and it's kind of a long legacy that we're able to share down here in Orlando. So what is it that I do? So I'm a beginning to end shoulder and elbow surgeon for adults and adolescents. So that means I take care of younger patients that may have some shoulder instability, middle-aged patients as they may get some rotator cuff tendon injuries, and then of course wear and tear injuries in older patients. And then with the elbow, I take care of everything. And so that's kind of my practice setup. With the shoulder, if you're younger and have instability, the shoulder is a ball and a socket joint, right? So it's similar to the hip, except the socket is much shallower. And so the shoulder relies on a lot of soft tissue constraints to keep it stable. Some of those are muscles, but one of those is the labrum, and that's a soft tissue ring that goes around the socket, and that can become injured if you have a shoulder dislocation. And if you have a lot of shoulder dislocations, you can actually begin to wear away bone. And so those are all conditions that I address in younger patients. As we all get older, no matter who it is, your rotator cuff muscles and tendons begin to degenerate. So your shoulder has 4 rotator cuff muscles that you can see here on the right, and those serve not just to increase stability of your shoulder, but they actually help to raise your shoulder and elevate your arm with power. And so when those tendons become either torn or degenerate or thin, you can lose a lot of motion, you can lose a lot of strength, and it can become very painful, particularly at night. And so those are conditions that I address arthroscopically. It's able, in a minimally invasive way, we're able to repair and augment those tendons to help get you back to the activities you were used to and help relieve some of your pain. Wear and tear disease is the result of long-term shoulder degeneration, though, and that happens in middle-aged to older patients, and that's going to be kind of the focus of this talk today. And shoulders can just wear out as you use them more and more, similar to hips and similar to knees. The shoulder, fortunately, is less of a weight-bearing joint than the lower extremity joints. But my goal for every patient that I see with the shoulder, particularly in rotator cuff and shoulder degenerative conditions, is to treat your pain and improve your function without surgery for as long as possible. The surgeries that we do for the shoulder are very, very successful, but there's no surgery that has no risk. Every surgery has risk, no matter how low it is. And so I don't take the decision to go to surgery lightly, and you definitely should not as either. And so I try to take the patient and guide them through a journey of as many non-operative treatments as possible before considering surgery. So what are those? So the best options for conservative treatment involve over-the-counter medications like anti-inflammatories, Tylenol, ibuprofen, naproxen. Things like physical therapy targeted to your rotator cuff or targeted to your shoulder can really help with strengthening and help train the other muscles, healthier muscles around your shoulder, to compensate for some of the structures that may be injured. Another thing that you can try is steroid injections. So these, of course, are not going to heal a rotator cuff tear. They're not going to solve your shoulder arthritis. But what they can do is give you some pain relief and help you to work with physical therapy better. And in many patients, that's really all they need to get them through and help to postpone surgery for as long as they possibly can. There are a variety of other things that people try. There's some less evidence around them, but it's definitely things that my patients have tried and sometimes will have success for. Some of them include like gels, like diclofenac gels, pain patches, acupuncture, or chiropractic. Heat or ice can help, and exercise. And these things don't necessarily have the evidence that the best options above do, but some patients like it, and so it's sometimes worth trying. But of course, when you do have wear and tear of your joint, it can be a challenge, right? And the analogy that I draw is actually with tread on a tire. And so Jiffy Lube is not co-sponsoring me with this, but feel free, Jiffy Lube, to give me an NIL deal or something like they do in college football. But I really like this chart because it's sort of similar to the thought process with shoulder replacement, is that it's a wear and tear disease, and it's very difficult to put tread back on a tire. You can't really do it. And whether or not you make the decision to replace your shoulder, replace your tire, depends both on how much tread you have left on the tire or soft cushion you have left in your joint, but also what your demands are, right? And so you may, like, if you're using a tire in snowy conditions or wet conditions, or you're a patient with like a high activity level or maybe a lower activity level, you may decide that you're ready for a joint replacement at a different time than someone else. And so really the decision is individualized, and it's something that I have a long conversation about with patients in clinic. It's kind of a patient-centered discussion that we have together, and to find both the right time for it and what the most appropriate treatment is. So just very briefly learning a little bit about the shoulder. So these are x-rays of a patient's left shoulder, and this is what a normal shoulder looks like. So the shoulder is obviously a ball and a socket joint. The ball is the humeral head. You can see that labeled there. And the socket is called the glenoid. So that's a bone that's part of your shoulder blade, and that's the socket portion. And in between the ball and the socket, the humeral head and the glenoid, is the joint space. And that gap right there is very healthy, and we like to see that gap. That represents the cartilage or the soft tissue cushion that exists in your joint. And that doesn't show up on x-ray because it's not bone. Soft tissue doesn't really show up on x-ray, just proxies for soft tissue. And so we like to see that really nice, healthy space between the glenoid and the humerus and the ball and socket. When you have worn away your joint and you have severe arthritis, that's the wear and tear disease that we were talking about. And you can see the difference really clearly in this x-ray here. So that joint space that represents the cartilage, the soft tissue cushion, is just completely worn away in this patient. And when that happens, there are a few things that go along with it. So you'll see the bone become sclerotic. That's a fancy term for saying that the bone becomes white on x-ray or very hard around those areas. And then reactive bone can form. You'll see kind of on the inferior or the bottom aspect of the head, the ball right here, you can see some reactive bone is forming. That's what something called an osteophyte. Some people call it a goat's beard. It's the beard underneath the goat's head. But those are all indications of a shoulder that has very, very advanced wear and tear disease. So that's isolated glenohumeral arthritis, isolated arthritis of the humeral head and the glenoid, the ball and the socket. But in this case, this patient's rotator cuff may actually be in good shape. Another disease that you can have of the shoulder is something called rotator cuff arthropathy, and that's when the rotator cuff is not in good shape. So remember, your rotator cuff is the set of 4 muscles that come across, turn into tendons that attach on the top of your humeral head, and they're what allow you to raise your arm with power. And as we get older, those tendons can tear and degenerate. And what can happen is those tendons, instead of being able to hold the humerus down, they no longer are able to do that. And so the humerus migrates upward towards the bone right above it, which is called the acromion. It's just part of your shoulder blade. And it can actually migrate so far that it can even touch that top of that and begin to wear it away. So you can see the difference in the x-rays on the left and the x-rays all the way on the right with rotator cuff arthropathy. The interesting thing is sometimes with rotator cuff arthropathy, it's an isolated rotator cuff issue, and the patient actually has no true glenohumeral arthritis. They have great looking cartilage, both on their glenoid and the humerus. It's just that the rotator cuff is so damaged, they get an x-ray that looks like this. And the reason we make a distinction between these is it informs our treatment actually. And so it's really important to understand. So this is the critical question we always have to answer, is basically, what is the rotator cuff status? Is it intact or is it not intact? If it's intact, we can just replace the worn out parts. And if it's not intact, we can replace and reverse the worn out parts. And I'll explain that in a second. But that's essentially the question we always have to answer. So let's start out with the simpler case. The rotator cuff is intact. We just need to replace the worn out parts. And that's what's called an anatomic total shoulder arthroplasty. Arthroplasty is just a fancy name for replacement. And this is for patients that have a healthy rotator cuff. And what we essentially do is we take the humeral head, the ball, and we replace it with metal. And we take the socket or the glenoid, and we replace it with a very, very hard, dense plastic material. And that essentially creates your new shoulder joint. So you can see here on the right what that plastic component looks like before it's put in. We put a little bit of bone cement in each of those peg holes there to help hold it in. And then you have the ball is just replaced by this metallic component. And this is typically a cobalt chromium alloy. It's a very hard material, and the plastic is very hard as well. It has unbelievable wear properties compared to what it was maybe 20 years ago or so. 5 to 10 years ago, what did anatomic total shoulder arthroplasties look like? Well, they looked something like this. So they had big very long stems that went very far down the humeral canal. They often didn't have all of the head sizes available to match each patient's anatomy. And so, due to those limitations, sometimes you had to make compromises as a surgeon back then. And so, as systems have evolved and gotten better, we now have much more options and much better options too. And so, what I use and what our group uses are stemless designs that are bone preserving for these replacements. So you can see the big difference on the left with that long stem with the stem on the right. And that is number one, bone preserving, which is great. Of course, the humerus and all long bones are essentially hollow in the middle. They have a canal. So is it really bone preserving? Sort of. But I'll tell you, if something were to go wrong with this, it's much, much easier if you have to remove this to remove the prosthesis on the right than it is on the left. And I think it's probably easy for you to see why. There's also improvements with the other side, the glenoid, the socket side. So different patients have different shaped sockets or glenoids, and some have even begun to wear away the bone. And so we now have improved components that are patient matched, that match the specific anatomy that a patient has. And so those are really the innovations in anatomic total shoulder arthroplasty that we have today that are giving us just really great results. But what about what we do for younger, very active patients with arthritis? Remember, this is an innovations talk. And so we're looking at the new things that we have to offer patients with unique problems. So younger, very active patients. So this is no longer a 60-year-old with arthritis, but maybe a 40-year-old patient with arthritis that's very active, maybe chops a lot of wood or uses a chainsaw or does some type of like very active labor or a sport or weightlifting. And they have x-rays that look like this, right? And so you can see very obviously this patient has arthritis. They have the osteophyte underneath the humeral head, but they don't have a lot of migration of the humerus upward. And so they probably have an intact rotator cuff. And so what can we do in a patient like this? Well, we could do an anatomic shoulder replacement like we just saw. There's a couple issues with that. This patient is young, and so they'll likely have this replacement for a very long time. And so we want the plastic part on the glenoid, that very, very hard plastic, to last for as long as possible. Also, this patient's very active, so they're really going to be stressing this implant. They're young, they're going to be doing a lot of heavy duty things. And we want to be careful about the shear forces that are placed on that glenoid implant. And so in an ideal world, we wouldn't have to place it. So 3 to 5 years ago, and even before then, what we would have done is what's called, kind of colloquially, a ream and run hemiarthroplasty. The hemiarthroplasty just means that we're only replacing one side, in this case, the humeral side. And we just decide not to place a glenoid or a socket component because of those concerns. So what we'll do is place the humeral component and then kind of smooth down the socket. The issue with doing this has some success, but one issue is that the metal head is so hard that it can wear away the glenoid bone. And so what we're talking about here, if there's any engineers in the audience, is modulus of elasticity. So the modulus of elasticity for bone is about 20 to 25. Modulus of elasticity for the metal alloy that's used in this is about 10. So it's really a huge difference. And this prosthesis is so hard that it can wear away the glenoid bone. And so today, an option that we have to treat this, and this is relatively recent, but there's very good outcomes with it, is pyrocarbon hemiarthroplasty. So similar to what you see on the left, you still don't need the glenoid or socket component for these younger patients, but the pyrocarbon is a very special material that doesn't wear away the glenoid bone as much or the socket as much. And the reason why is because it's a softer material. It has a modulus of elasticity that is much closer to bone. It's about 15, whereas bone, remember, is about 20 to 25. And so that has big advantages. This is what it looks like on the left. So it looks kind of space age like. It's a black prosthesis instead of a silver prosthesis. But the applications for using this really are rapidly expanding. So again, this talk is about innovations in shoulder replacement. So this is what we use now in younger, very, very high demand patients, like say a 40-year-old weightlifter or something like that. But I think it's an open question as to what the future looks like. So right now, we still do anatomic replacements because that's what we know the most about, and they have very good success. But maybe in the future, we can start using more of these where we don't actually have to place a glenoid component. But that's something that remains to be seen. And we still need the studies to be able to look at that and to see whether or not that's supported or whether we just need to have both sides replaced. So that's one recent innovation in shoulder replacement. So back to this critical question we always have to answer. So what is the rotator cuff status? So we already talked about what you can do if the rotator cuff is intact. You just replace the worn out parts using an anatomic replacement. But if your rotator cuff is not intact, you have to replace and reverse the worn out parts. I promised I would explain what that means, and we've gotten to this point now. So if you don't have an intact rotator cuff, you do what's called a reverse total shoulder arthroplasty. And there's a few key points with this. It's still, your shoulder is still a ball and a socket joint, but we actually reverse the ball to the socket side and the socket to the ball side. And from now on, I'm going to start referring to it as the glenoid and the component and the humeral component, just for clarity. So what this does is it essentially retensions the shoulder. So the shoulder no longer relies on the rotator cuff to raise your arm because you don't have a rotator cuff or your rotator cuff is not functioning well. And so this allows the deltoid muscle, which is the large muscle on the outside of your arm, to substitute for that deficient rotator cuff. And that happens because we change the center of rotation of your shoulder and we retension it. And this is what the x-rays look like essentially. So you can see how there's a sphere or a glenosphere on the glenoid side. And that is attached to the glenoid and fixed there with several screws, 4 to 5 screws often. And then you have the humeral component with a short stem, and that serves as the socket. So it's essentially reversed around the ball and the socket part of the joint. But this is an innovations talk. So what are the new parts of this? Well, 5 to 10 years ago, this is what the implants looked like. So they were quite large. They had long stems. And they had an angle that was designed for increased stability or optimal stability. But along with that came some complications, one of which you can see in this x-ray that I won't really go into. But as we've learned much more about reverses over the past 5 to 10 years, we've optimized the designs. And this is what they look like today. So there are short stem options that are bone preserving. Many people still use the long stem options, and those are great as well. The short stems can be maybe a little bit easier to revise if you ever needed to, heaven forbid you ever needed to take it out. There's also optimized designs. So we've now optimized the angles that the prostheses or the devices are made at that help with patient motion, pain, and eliminating impingement where the bones are pressing up against each other. We also have patient-specific augments or patient-specific instrumentation that helps match the components to a patient-specific anatomy. And so those are all targeted in a patient-specific way. But this is essentially what reverse total shoulder arthroplasty looks like today. And now I just wanted to take a moment to go through a demonstration of how I plan for cases, both for anatomics and reverses. So let me switch tabs here and log in really quick. Whenever a patient and I decide to go and undergo a shoulder replacement, each patient is going to get a CT scan. And the reason for that is so we can do preoperative planning so that I can essentially do the surgery beforehand on the computer so I know exactly what to expect. You can plan the implants. You can look for things that you may have to watch out for in the surgery, and that's the purpose of the CT scan. And so what you can see here is this is a patient that has a CT that had very bad arthritis, so glenohumeral arthritis, but it looks like the rotator cuff is intact. Ultimately, the rotator cuff is a clinical judgment call, but we'll just sort of assume that this patient has an intact rotator cuff. You can see the 3D reconstruction right here on the right, but we'll decide to plan for an anatomic total shoulder replacement. We'll assume that the rotator cuff is intact. And so what you can do is you do the surgery on your computer before the surgery, so you know what to look for. And so we're going to do that right here. I'm just going to change these implants around a little bit. This is a fairly big implant in this patient. So I think I'm actually going to switch it to a small. So this patient might be a female patient that has maybe a little bit smaller bones. I'm going to rotate it around a little bit. And you can see here on the right on the CT scan what the implant looks like as it's in. And so it's in actually a fairly good position right now. I don't see any perforation of the pegs. We may see that as we go in, and in fact, we do. So we have to be careful of this, right? So you can see a peg is coming through here, and the only way I would have really known this is by doing exactly what I'm doing right here, which is going through this surgery on the computer beforehand. So I'm going to put it in one more, and that looks great. So notice, you can see here, another of these pegs is perforated through. And this is one of the ones that we would consider cementing. So now I know in the surgery to be careful. Okay, in the front, I've got to be really careful when I'm putting this component in, and may not be able to put any like cement right here in this component. So this is the socket or the glenoid component. Let's look at the humerus. So this is what it looks like. I'm going to take off this right here so you can see it a little bit better. And so you plan separately both the glenoid and the humeral components. So let me change this to the performance stemless. And again, you have this very small stemless design here. So it's bone preserving. This actually looks like a fairly reasonable fit. I may move it a little bit down here, but you can essentially then go through the CT scan to see whether you like the fit of it or not, to determine what type of implant you'll use in the patient. Now, you may get in there and the anatomy could look a little bit different than what it looks like on the CT scan. And so you may end up using different sized implants, or maybe the patient's bone quality isn't what you expected or hoped. And so, but this is just a guide that you can use to inform your decision. And then you can put it all together and see what it looks like. And this is what the anatomic total shoulder replacement looks like when you actually put it all in. So that's an anatomic. But what about the reverse? So remember, the anatomic is for when you have an intact rotator cuff. What about when you don't have an intact rotator cuff? Well, let's look at another patient here. This is where you do a reverse total shoulder arthroplasty. So remember, you're switching around the ball and the socket joint. You're retensioning the shoulder. So you're no longer relying on your deficient rotator cuff, but you're rather relying on your deltoid, the large muscle on the outside of your arm. So you can see in this patient, the CT scan, again, this patient's undergone a CT scan beforehand, so I can plan the surgery and do it on the computer beforehand. So they've worn away a ton of bone here. You can see this on the glenoid side. Your shoulder on this view should look sort of like a golf ball and a golf tee, and you can see they've worn away just a ton of the golf tee. I'll show you a little bit better right here. You can see just in the back there, they've worn away a lot of that. And so that's something that we have to think about and plan for as we're going through this. So we're going to plan for a reverse. We're going to assume that on exam in clinic, the patient's rotator cuff was not healthy. And so what we'll do, again, we can start with an augmented glenoid component. So that's going to make up for the bone deficiency that you can see there. And we can position it how we want. So we're just going to bring it into the bone right here. And that shows the amount of coverage we're going to have. I'm going to rotate it around just a little bit. The whole point in having these sort of patient-matched implants is so that in preparing the bone to accept the implants, you have to remove as little bone as possible. You want to have as much of a bone-preserving surgery as you possibly can. And that really is the goal with all of this. And so this looks fairly good. This is a fairly large patient. So the largest sphere is actually probably going to be the best option for this patient. That may be a male patient. And not only are you able to see these components, but remember, this is fixed to the bone with a set of screws. And now you can actually plan what those screws look like by turning on this option. And you can say, okay, like plan not only how big you want your screws to be, but also the trajectory. So I can say, okay, this screw is 26 millimeters long, but it's probably too long right here, but I can get a longer screw, which is good, by adjusting the trajectory a little bit. So that looks like a really good trajectory, and I can get a size 26 millimeter screw in there. And you can sort of anticipate where screws are going to be, where you can put them, where the best bone is. before you actually get into the case. And so normally I would spend a little bit more time on each of these preparing for the cases, but just for demonstration purposes, I'm just kind of showing you the broad outline of what I do. What about for the humerus? So we did the glenoid. That's the ball, remember, the glenosphere. And this is essentially the socket. So you can see right here. This is what it looks like. Again, this is a somewhat larger patient. So we have a somewhat larger stem size here. I'm going to bring the resection level to take a little bit more head right here, and then bring it a little bit more inframedial. And I think that looks pretty good. If it's a male patient, I'll actually use a asymmetric plastic liner for it as opposed to a symmetric one. And in female patients, I'll use a symmetric one that increases their lateralization. But in male patients, I'm a little bit more concerned about stability. And then you can put it all together here and see what it looks like in the computer and play through the motion and to see what the areas of impingement are, what the bony landmarks are that you need to be aware of, and what things in surgery you may need to address to improve range of motion. So here's one area. There's some bone up here. When the patient raises their shoulder up all the way, I may need to remove a little bit of this bone in the surgery to make sure that they're able to get full range of motion. Now, I'll be honest with you. Templating software can only take you so far, and it doesn't account for the position of your shoulder blade, your specific shoulder blade. All it does is kind of line them up square. And so the range of motion is just sort of a rough guide, and I don't put a ton of stock in it, but there are some things that are like kind of obvious things that it can show you, and that's why I find it to be really quite beneficial. And so you can see what your correction of all of the deformity looks like, what their anticipated range of motion is, and where the areas are that the patient might impinge and have pain. And you can do this all before the surgery. And so I think this is a really valuable tool, and I do this for every shoulder replacement that I do. No matter what, beforehand, we'll get a CT scan, plan it, so I know exactly what is going to happen going into the surgery. And that leads to predictable and, in my opinion, and in my hands, more safe outcomes. So that's the demonstration and what we do for each arthroplasty. But again, this is about innovations. And so what are some of the new innovations that we're doing for shoulder arthroplasty? And this is for the more complex cases. So we talked about the newer implants that are for more standard cases, but this is for the harder cases, maybe the patients that have failed a prior surgery. So in this case, this is a case I was involved in last year, and basically they had a replacement that was done in the early 2000s. And there are this is a very old implant, a very old prosthesis. Again, they didn't have as many options. And so this isn't really quite the position that I would put this prosthesis in. But what's happened over time is, number one, their rotator cuff has degenerated. Number two, they've worn away all of the bone in their socket. Remember, there's a big difference in the modulus of elasticity, how hard the metal is relative to how hard the bone is. And so you can see on the right here, this dark gray is their native bone, the bone they used to have. And this prosthesis here has worn away all of this bone. And so if you're trying to convert this patient that has pain to a reverse, you have to essentially figure out how to compensate for and make up for all this bone that's been worn away. And the one way that we can do that is with custom 3D printed implants. And so again, as always, you get a CT scan, get 3D reconstructions, and what you can do is build a component that exactly matches up to that patient's deformity, the bone loss that they have in their socket. And you can create a heat map that shows you where the best bone is. You can see with the red and the green there. And that doesn't just help you know where to place the component, it can also help you with the trajectories of the screws that you're using to make sure that the implant is rock stable in there and grows into the bone really nicely. You want those screw trajectories to be heading towards the best bone possible with the longest, most stable screws possible. And so this is something that allows you to do when you custom design an implant for these hard cases. And this is what it looks like after the surgery. So you can see that where the 3D printed portion goes all the way up along here. And then we had removed the stem, placed this new stem. and turned it from an anatomic, or I should say, yeah, an anatomic total shoulder arthroplasty to a reverse total shoulder arthroplasty, but it required some advanced technology to be able to do this. And it's pretty amazing because these implants actually fit so well in the surgery, and even the screw lengths that are pre-measured often are almost exactly what you actually end up putting in and measuring. So that's an innovation in shoulder replacement, is these custom 3D printed implants. Maybe in the future, in 10 or 15 years, we'll have a custom implant for every patient. As of now, that's not really needed and the cost is very prohibitive. But just know that if you're a patient that has a complex shoulder issue, these options are available to you, and we can plan a custom implant for your specific bony anatomy. What about for even more complex cases where the patients maybe had some issues and they come to you and they say, and they have a ton of bone loss of their proximal humerus. So what are you going to do then? In the previous patient, they had bone loss of their glenoid, the socket component, right? This patient is different. They've lost bone on the humeral side, their arm bone. So we now have what are called proximal humerus replacements. And so now these have limitations. And so if you're a little bit younger, you may actually replace this bone with cadaver bone from a cadaver donor. But if you're a patient that's maybe a little bit older and lower demand, you can actually just replace the entire proximal humerus with metal. And these x-rays are essentially what that looks like. So this is just another example of the new technology that's possible to make up for big bone defects. Now, moving more towards the pure technology side, just a couple more examples before we get to some questions. So mixed reality. What is mixed reality? Mixed reality is essentially a digital overlay onto the real world environment. So essentially, what it is you can put on goggles, and this is already here. You can put on goggles, and during the surgery, you can see the 3D templated plan that you created. Remember those plans that we just created about 10 minutes ago using the software? You can have that as part of a mixed reality hologram right in front of you, and you can manipulate it with your hands. And so you can see what the patient's bone looks like. You can see what the implants are that you've planned, including the sizes. You can see what position they're in and where you want to place the components. And so it really is a very helpful thing. And I've done some cases with it, and I really do like it. I'm waiting for it to become more compatible with some of the infection control measures that are my personal preference in terms of gowns and hoods. But it's definitely something that I think has essentially a future in many of our practices, including mine. It is already here. I've used it. It's a really cool technology. I will say, as with many of these new technologies, they are great. There are no studies that have proven any clinical benefits yet, right? So there just really isn't any evidence that this actually helps with patient outcomes. And as a surgeon, that's what I care about most, right? I care about how well the patient is ultimately going to do. And I'm not going to use cool technology just for its own sake, especially if it interrupts my workflow. And so if you do find it helpful, though, this is something that I think is going to become increasingly common, particularly as the technology gets a little bit better. But this is already here in the form of mixed reality. And of course, no talk on innovation in replacement is complete without talking about robotics. So robotics has been in the arthroplasty world for hip and knee replacements for actually quite a long time now. And there's quite a lot of literature on it, but it's actually only now coming to the upper extremity, specifically the shoulder. And the first robotic assisted shoulder replacement was performed in Rochester, Minnesota, actually only in April of 2024, so very recently. And this is something that's still gaining traction. We're still sort of figuring out the best context to use it in, but similar to hip and knee arthroplasty, hip and knee replacements, there aren't proven clinical benefits yet in terms of actual patient outcomes. So if you look at what robots have given to surgeons that do hip and knee replacements, they'll tell you, and all the studies show you can make more precise cuts. You can get the implants better positioned. You can do a bunch of things like more reproducible, a lower margin for error using robotics. But there haven't been studies yet that have showed a consistent difference or improvement in patient outcomes, an improvement in pain, an improvement in function, an improvement in range of motion. And so that's really the gap that I think many of us as surgeons, and in particular shoulder surgeons, are waiting for. We're waiting for the studies to show the improvement in the patient's actual outcome. Again, we shouldn't use technology just for its own sake, just to do it. It's good to push the envelope, but the priority is the patient outcome. And anything that interrupts your workflow in surgery, there has to really be a proven demonstration that helps with that. And so for this, robotics and shoulder replacement is still very, very much at the outset. We're still very early going with this, but I think there is a future for it. It's not quite here yet. But that's kind of what that is. So that actually brings us to the end of my prepared presentation. And so at this point, I think maybe we can go through some questions if any of you have any with Aliana.
Thank you, Dr. Goltz. That was great. We do have two questions. The first one is from Carl. My name is Carl, and in the past, I've had rotator cuff surgery on both shoulders. Both surgeries failed. My left shoulder has now deteriorated further, and I'm left with constant pain and minimal strength. My ortho surgeon says not to do shoulder replacement unless the pain is not tolerable. Therapy has not worked, nor shots. Is his view antiquated?
It's a great question. I'm sorry to hear that, Carl, but it's unfortunately a story that we hear a lot. And rotator cuff repairs largely do very well. They're often very successful surgeries, but as we all age, like I'd said, the tissue quality just degenerates, and it's just a natural process of aging. And so the fact that you have pain from that may mean that you're a candidate for a reverse total shoulder replacement. And, I can't speak to what the other orthopedic surgeons that you've seen have, and I would have to see you in clinic and review your imaging and all of that. But I will tell you, if you have minimal rotator cuff, the reverse total shoulder arthroplasty can be a great option for you with quite reproducible results. And so what are those results? What can you expect? And this is something that I tell patients in clinic every time we kind of go through the discussion. So pain relief is the biggest thing, and that is almost immediately noticeable within the first week or two following surgery. When you have a rotator cuff that is torn, or say you've had a surgery that's failed, it is painful, and the pain is especially bad at night. It's especially bad with overhead activities. If you're reaching into a cabinet to take a dish out of the cabinet or anything like smaller than a coffee cup, it can be brutally painful. And so when you have a reverse total shoulder replacement, that's the first thing that patients notice. And we can reproducibly impact patient pain and resolve a large, if not a complete portion of that. But it can also help with function too. So what function can you expect? You can expect to get your arm above your head, okay? And so you can be able to complete daily activities. You can wash your hair, you can shave, you can even take stuff out of cabinets. Many patients that have reverse total shoulders that are relatively healthy and active actually can return to sporting events as well, like low impact, kind of gentle activity sporting. We have some pickleball players that have had reverse total shoulder arthroplasties, and they've gone back to playing pickleball. But the motion and strength is a little bit less predictable, but it generally is very good. So you'll gain movement in front. You may lose a little movement behind your back, but for many patients, the pain relief that you get from the reverse and the improved function is well worth the risk. It's a great question, Carl.
We do have another from Carl. Is the deltoid detached and then reattached for this surgery? What is the normal recovery time compared to normal rotator cuff surgery?
Good question. We actually don't touch the deltoid. And that's one of the principles when you're a shoulder surgeon, and particularly when you do kind of complex shoulder reconstruction, there are two things that you want to preserve. One is glenoid bone, the socket bone, because if you still have glenoid bone, you can do a lot of things. And the other thing is you want to preserve the deltoid, and that includes the deltoid attachment. And so For me and for all shoulder surgeons, we are obsessive about preserving the deltoid and the deltoid attachment. So there are very, very few cases or situations in which we would ever touch the deltoid or the deltoid attachment. That's something that we are being very careful to preserve, because ultimately that's what's powering the reverse, right? Like, you're able to get motion because it's your deltoid that's giving you that motion. It's a great question.
We have another from Alicia. How long is shoulder replacement surgery? What is the pre and post physical therapy timeline?
Good question. So the surgery itself takes between an hour and an hour and a half. It'll seem a little longer than that to you because you'll have to come in, you'll undergo some anesthesia, you'll get a preoperative nerve block that'll last anywhere from 24 to 72 hours, and that'll numb your arm and take care of the pain that happens immediately after surgery and kind of get you through that immediate postoperative period. Surgery itself takes, like I said, hour to an hour and a half. And then you're for a few hours in the recovery period. About 80% of patients go home the same day. So if you're reasonably healthy, that would probably be your scenario. If you have some medical issues like diabetes or heart issues or lung issues, that doesn't mean you can't have the replacement. It just means you may need to have it done in a hospital and spend a night, as opposed to having it done in maybe an ambulatory facility where you'd be able to go home the same day. Probably about 80% of patients end up going home the same day, and most patients much prefer to spend the night of surgery at home in a comfortable environment that they're used to, rather than in the hospital. And then in terms of the postoperative period, with anatomic total shoulder arthroplasties, you'll start physical therapy at around the 2-week mark. So that's when you'll start it for anatomics, and that will typically last for anywhere from 4 to 6 weeks, working on your range of motion and in your strengthening. For reverse total shoulder arthroplasties, recent studies have actually shown that there is no requirement to have formal physical therapy sessions after reverses. And studies have shown equivalent outcomes between patients that have had formal physical therapy and have not had formal physical therapy and have just done at-home exercises after reverses. So I leave it up to the patient, and it's very patient individualized. So if the patient, wants someone kind of supervising them and motivating them, then they're welcome to have some physical therapy. But it's by no means mandatory after reverse total shoulders. By the way, for primary replacements, I see you at the 2-week mark. You just have a single incision that's about 4 or 5 inches long down the center of your shoulder. It's right here. There's no stitches that have to be removed. It's all absorbable suture material, so you don't have to worry about having stitches out in your first post-op 2 weeks later. So it really does become a very smooth recovery. And physical therapy, although it is important for anatomics, it's very much optional for reverses. Good question.
We have another from Joelle, who's a PT in the Kissimmee area and has seen traditional total shoulder arthroplasty and reverse total shoulder arthroplasty. What would be the implications for risk of dislocation or precautions early on with some of these newer techniques being implemented?
It's a great question. Dislocation is not really a problem in anatomic total shoulder arthroplasty. Instability is a potential complication in reverse total shoulder arthroplasty. And what that essentially means is the ball and the socket just kind of move out from one another and dissociate. All the components are still well fixed, but your shoulder can dislocate. In primary cases, primary reverse total shoulder arthroplasty, that happens 1% of the time. So in 1 out of 100 cases, so it's a very, very low risk. It's something that we know very well how to address and how to kind of do our best to prevent during the surgery. But you're right, there are some precautions that patients can take in the period following surgery. If patients dislocate, it happens on average at 7 weeks at 7 weeks following the surgery. So if you're 3 months out, you can have some comfort that it probably will not happen, although it can happen later on. A few of the motions that we try to avoid, one is reaching behind your back and essentially internal for the physical therapists out there. So extension, internal rotation, and adduction. That's one of the motions that we try to prevent. We also, or at least in the initial postoperative period, as your arm kind of heals around your prosthesis, We also are a little bit careful with like large external rotation maneuvers, particularly in larger male patients or maybe high BMI patients that have a larger soft tissue envelope that could act to almost lever the prosthesis out. So it's a great question. Instability is something that we do see in reverses, but it fortunately happens in only in about 1 out of every 100 cases. So it's a fortunately very rare complication.
Question for Marianne. Please tell me why the rotator cuff pain is worse at night.
It's a good question. I don't think we necessarily know that yet. I'll be honest, it's a physiologic process, and it may be the type of thing where as your brain has less stimuli going to it from the outside world, it's freer to focus on some of the musculoskeletal issues that are happening. But I actually don't know of literature that looks at that or really explains why. But it's one of the first questions that I ask of patients when I see them in clinic, and I suspect that they may have a rotator cuff tear, is oh man, they so frequently have pain at night, and that's almost the worst part of it.
And last question from Freddie. What would be the approximate recovery time after shoulder replacement?
Great question. So after a shoulder replacement, and I would say it's probably pretty similar between anatomics and reverses, I would expect you to have about 80% of your eventual result by the 3-month mark. I expect your pain to be much improved by the 3 or 4 week mark, and then it's a matter of gaining strength, gaining motion. But you're at about 80% of your final result by the 3-month mark. The good news is you will continue to improve up to a year after surgery. And that final 20% happens in months 4 through 12. And so if you're at the 3-month mark and you're happy with where you're at, but you'd like to get a little bit more, you can kind of rest assured that you will continue to improve up to a year out from surgery. You get 80% of your eventual result within 3 months, but a lot of your pain is gone by the 3 or 4 week mark. And then between that and the 3-month mark is where you're working on strengthening, you're working on range of motion, and you're getting used to using your arm again. Great question.
And that concludes all of our questions, Dr. Goltz. So thank you all for taking time out of your schedule to join us this afternoon. And thank you to Dr. Goltz for sharing such valuable information. I hope you all found this information extremely helpful. And if you still have any questions, please email me, which you will find in the chat box at the bottom, and we will get back to you as soon as possible. Again, if you would like to make an appointment, please call 1-844-407-4070 or go to rothmanortho.com. Thank you.
Thanks, everyone.